Welcome to this video on neurodivergence and comorbidity. We will explore current evidence on psychiatric and medical comorbidities in conditions like ADHD and ASD, with a focus on the clinically significant but under-researched effects of female hormonal influences. The neurodivergent spectrum includes conditions like ADHD, ASD, dyslexia, and dyscalculia, each with specific neurobiological profiles. A significant finding is the high co-occurrence of ASD and ADHD, or AUDHD, estimated at 50 to 70%, which leads to greater impairment than either condition alone. Comorbidities are the rule, not the exception. The psychiatric burden is high. 68.8% of autistic adults have at least one psychiatric comorbidity. Conditions like anxiety, depression, and emotional dysregulation are common, with rejection-sensitive dysphoria affecting up to 70% of those with ADHD. Symptom overlap and diagnostic complexity arise because conditions share neurobiology, leading to a symptom lattice. Executive dysfunction, sensory differences, and social cognitive challenges appear across multiple conditions. Specific executive function deficits, such as inhibitory control in ADHD or cognitive flexibility in ASD, can help delineate profiles. Diagnostic frameworks often fail women. Male-centric criteria result in delayed diagnosis and misdiagnosis for females. Practices like masking further delay clinical referral. This leads to autistic girls being diagnosed years later than males, a significant recognition gap that is a public health concern. Neurodivergent individuals face significant long-term outcome gaps compared to neurotypical peers, including 50 to 80% autistic unemployment, a 3 to 10 times higher suicide risk, and a 16 to 24-year life expectancy gap. These gaps reflect systemic barriers, not inherent neurodivergent incapacity. Hormones significantly affect neurodivergence. Estradiol modulates key neurotransmitter systems, causing state-dependent changes in symptoms throughout the menstrual cycle. The follicular phase may bring improved clarity, while the luteal phase can exacerbate symptoms like attention and impulse control. Hormonal periods like puberty and perimenopause unmask previously compensated neurodivergence. Approximately 45% of women with ADHD experience PMDD, significantly higher than the general population. Estradiol volatility can trigger acute decompensation in perimenopause, often resulting in the first clinical presentation. A comorbidity-informed approach to treatment includes transdiagnostic assessment, looking beyond one condition at a time. Cycle-informed prescribing may involve adjusting stimulant efficacy across the menstrual cycle. Adapted psychological therapy and accommodations address structural barriers to performance, not intrinsic incapacity. Comorbidity is the rule, diagnostic frameworks fail women, and hormonal biology is clinically significant. Outcomes reflect systems, not incapacity. The most immediate priorities are cycle-informed clinical practice and neurodiversity-affirming frameworks to address these gaps. Visit neuronavigation.org to learn more.